My name's Stephen Kidd. I'm a clinical scientist from Hampshire Hospitals, and one of my roles at Hampshire Hospitals is to evaluate new technologies, particularly in the sepsis pathway. And so today's talk is one of my MSc students' projects where we are looking at evaluating a novel rapid AST. We've got a lot of experience at looking at these in our hospital for the last 10 years. So I'll be kind of having a bit of an overview of the end-to-end process for collecting blood cultures, the impact on good diagnostics, the impact on stewardship, and a couple of clinical cases along with some new analytical data from our most recent study. So straight into a bit of a clinical case just to kind of whet your appetite to show you the power of rapid diagnostics in terms of rapid susceptibility testing on bacteria grown from blood. Okay. So we had a 31-year-old acute myeloid leukemia patient who was undergoing chemotherapy. So these folks are sitting ducks for getting sepsis, for getting bacteremia, becoming septic. Okay, they had a recent C. diff infection and was subjected to obviously multiple antibiotic courses. So they were treated with oral vancomycin. So this case is a couple of years old. They'd had a recent enterococcal line infection, as you all probably know better than me, and you're very familiar with how troublesome line infections can be, particularly in those receiving chemotherapy. So they're already on prophylactic antifungals. So rapid clinical deterioration. So they're given empirical tazocin, as with most people with neutropenic sepsis, and some stat dose of amikacin. Positive blood culture so note the time, 6:30 in the evening, and the gram stain was a gram-negative bacilli. So those of you who aren't familiar with some of the nomenclature, this is one of the bugs which is most associated with sepsis, and we'll get to some of the identifications earlier, but things like E. coli, Klebsiella pneumoniae, these are gram-negative bacilli. So at the time, we're looking at how the impact of rapid antimicrobial susceptibility testing would impact this result versus our standard of care, which can take up to 24 to 48 hours to get a full result. We put it on the rapid system. The identification was a Pseudomonas aeruginosa. And what was interesting, and I'll stop here before I go and give some more details, is that we'd recently had an outbreak of multidrug-resistant Pseudomonas in this hematology oncology unit, which was a GS5 carbapenemase producer, so massively resistant, and the kind of bug you do not want in your cohort of patients who are massively immunosuppressed. Okay, so that will keep you intrigued until later in the talk to stop you going to sleep. And now I will just kind of introduce a bit more about why it's really important to get high-quality diagnostics into your clinical workflows in hospitals, not just for things like sepsis, but in general. Diagnostic stewardship is a really important thing, as you're all probably aware. You know, antimicrobial stewardship is really important, using the right antibiotics for the right duration, the right dose. The same goes for diagnostics, using the right test at the right time that has an actionable result. And this is why we do studies to look at the impact of these diagnostics, so we have an evidence base that they are worth the investment, because often these new technologies come with a cost pressure, and as we all know, the NHS has no money, so we all have to make sure we get good value for money. So there's been a big movement around the narrative of improving the sepsis pathway in terms of diagnostics, management, treatment, and part of that is the blood culture pathway. So making sure that we take the correct amount of blood culture bottles in an aseptic way, delivering them to the laboratory on time, and ensuring that they are incubated on time, and that we then have the best chance to isolate the bug which is causing a problem. So there's a lot of work around this, and this is part around the big narrative of the impact of AMR, the National Action Plan to fight AMR. So for those who are unfamiliar, AMR is antimicrobial resistance, which is a global problem, but will also hit hard at home in the UK as well. So this is something which luckily in our hospital we don't see very often, but this is a reality in other places around the world and is starting to move into hospitals within the UK. So this is a completely drug-resistant Klebsiella. Okay, so this is known as a CPE. So you're familiar with CPE. We screen for those people who repatriated from hospital stays in the overseas, and now some of the bigger UK hospitals as well. They are very hard to treat. So this is a New Delhi beta-betallolactase, and it is very resistant. And this could be the future. Okay, we've had an outbreak in our hospital of these, and they're very difficult to treat. So this is why rapid diagnostics are really important to reduce that diagnostic uncertainty. Obviously, we have empirical therapy, which is the best guess with the best data we have at the time, but it is a best guess. And generally, 90% of people will be treated correctly with good empirical therapy. However, that uncertainty is what's driving resistance when patients are given suboptimal antibiotics. So the core principles around introducing new diagnostics to improve these pathways, you might think are quite straightforward. There's a need, there's a potential patient benefit, but often they're not as easy to introduce as you might think. There's a lot of barriers to change. There's a lot of barriers around finance. There's a lot of barriers and resistance from the people who like the status quo. So these are types of things which scientists and clinicians like myself are often fighting against to bring in changing practice. And it's something that is difficult. So I don't know if you're aware of the theory of the distribution of innovation is a bell curve, and a lot of the community in which we live in are those who are slow to adapt and slow to adopt. So it's good evidence that helps to bring those colleagues of ours who don't like change on board, and this is the type of work that we do. So for those of you who aren't familiar, a diagnostic pathway which make up the clinical pathways which you probably all work within, we split up into three separate parts. So the pre-analytical, the analytical, and the post-analytical parts. So essentially the pre-analytical, if we can look to improve, so look for kind of incremental increases and improvements, we can probably improve the whole pathway. So things like the correct amount of blood culture bottles, the correct technique, so we're not contaminating them, ensuring that those samples are the correct ones, that they get sent to the laboratory, they get sent to your central laboratory on time, they're not just sat in a box in ED waiting to be sent to the lab at the end of the day. Then the analytical part is the, as you imagine, the laboratory diagnosis. Are we using the best available technology in the most efficient, cost-efficient way? And the post-analytical part is something that sometimes gets forgotten about. You can, if you invest heavily in some really interesting technology, some innovation, but the result doesn't get back to the clinical team that actually makes a decision based on that result, then the investment is wasted. So are the reports getting back to the right teams? Are the reports easy to understand? Are they going to action a change in patient management? So this is an example of the blood culture pathway that will be standard in most UK hospitals, with the timelines being fairly unchanged for the last 30 years. As you can see, the diagnostic uncertainty is the part where we're not 100% what the organism is we're treating, but we're giving empirical therapy to best treat that patient. But in terms of the suboptimal treatments, what drives AMR? So we want to bring in technology that reduces that diagnostic uncertainty, improves our diagnostic stewardship to ensure we're using the right tests at the right time. So this is where we can improve the turnaround time, so reducing that time to result can affect and improve patient management. So this is for those of you who aren't familiar with laboratory medicine, this is a standard generic diagnostic pathway. Blood cultures are taken, they're sent to the laboratory, ideally within 4 hours is the standard, because the more hours that a blood culture is not in an incubator, the drop in sensitivity is quite profound, especially those organisms like strep pneumos that can just lyse themselves. If they get incubated, then those that have enough bacteria in grow, they ping positive, they get processed by the laboratory. We then have to find out what the bacteria or fungi or yeast is. We then grow it, and we do antimicrobial susceptibility testing. So essentially challenging the bacteria. So I'll just talk about bacteria for the moment, but obviously we can do this with yeasts as well, things like candidas. We had to talk about Candida auris earlier. Obviously that's a nightmare if you get that in the blood. So we challenge the bacteria with antibiotics to see which would be the best ones to treat. Okay? So this is probably one of the first instances of personalised medicine. It's been going on for many years. We'll try and find what that bug will respond to. Okay? Now, as you can see, there are some interventions which have come in the last 10 to 15 years. We can now do rapid ID using multi-TOF mass spectrometry, but we're yet to crack really rapid antimicrobial susceptibility testing because that requires the bacteria to grow. And unfortunately, biology is not our friend here because they can be quite slow. So we're looking to improve that part, and this is what we've been doing recently. Okay, so we've kind of talked about this, and I'll skip over this for the sake of time. So we're kind of addressing an unmet clinical need, and that is rapid susceptibility testing. Can we improve patient care by getting a really quick result to be able to say this antibiotic will work, and how quickly can we do that? And this is where the innovation comes. Innovation doesn't necessarily have to be a sparkly, box that does all the things. Innovation could be around reducing a novel technique to improving how we take blood, reducing contamination rates, for example. It can be improving a pathway that already exists. It doesn't have to be something sparkly and new, but we do like sparkly and new things. Okay, so the focus of this talk is working with BACTEROMIC, who are a Polish company. We have in the laboratory, my MSc student Tom has been processing positive blood cultures using their novel analyzer to gather some proof of concept data and performance. So as we've discussed, the standard of care can be up to 24 hours to 48 hours to get full results on which antibiotics to use in the case of treating a patient. So can the impact of reducing that time impact patient care for the investment that will be needed? So this system produces a result within 8 hours, and it works with gram-positive and gram-negative bacteria. So they're the two groups of bacteria that we will inevitably be testing, and the throughput is really impressive. So for us, we could put all of our blood culture bottles through this. In previous iterations of other technologies we've looked at, sometimes we've had to triage which blood cultures we processed, but for this, all of our blood cultures could go on. Very simple workflow. That's the thing with laboratory medicine. The biomedical scientists don't like you to make their work days more complex. It's already hard enough as it is. So anything you do introduce has got to be easier or simpler or faster. Okay? Otherwise, it can be a challenge. So our workflow for this novel method, again, this is not anything that's massively different from the way we work. Our positive blood cultures, again, are unpredictable when they become positive. Now, interestingly, a lot of laboratories in the UK all work slightly different hours. There aren't as many 24-hour laboratories as you might think. Obviously, our colleagues in blood sciences, hematology will be running 24/7 because you need your full blood counts, you need your liver function tests done round the clock. But microbiology tends to not always be 24 hours. So one of the pieces of work we've done is actually we get our blood cultures loaded 24 hours because we have our blood culture analyzers in sample reception where samples are coming through all the time and it's manned 24 hours. That's actually seen an increase in our sensitivity. But as of yet, they don't get unloaded 24/7. So we do have samples that go positive during the night and don't get processed till the morning. But that's something for the future. So what we do when a positive blood culture is analysed, we do what's known as a sepsityper, which essentially is we get the positive blood culture, we spin down a pellet of bacteria, treat it, and then we blast it on the mass spectrometry, and we generally get an ID 90% of the time. Then we put it through the rapid antimicrobial susceptibility arm and also through our standard of care. So our current standard of care is direct dish diffusion, which is those plates with the little discs of antibiotics impregnated, with some follow-up work after 24 hours. So with the best will in the world, and as we all know, working in NHS can be unpredictable with workload. We haven't been able to process as many samples as we'd hoped to be able to present to you today, but we have 27 patient samples, so this is 27 patients who are septic, whose blood cultures that were collected have become positive, and we've identified a bacteria. So we have a number of, you see the bacteria across the top, and it's not unsurprising that E. coli is the number one, because that is the number one bacteria that gets isolated. It's one of the often associated with a urine source, as one of our colleagues talking about UTIs. You know, urosepsis is the number one cause of sepsis, and often it's by in E. coli. So this kind of spread of organisms is not uncommon. And so what we do when we first start a project, before we kind of delve deeply into all of the analytical parts of the process, because one of the really important things versus our standard of care is the bacteriomic system produces a full MIC range. So this is the minimum inhibitory concentration of the antibiotic. So this produces a range as opposed to just a sensitive or resistant that you would probably see on reports, which is what you get with dish diffusion. So this can help with tailoring treatment sometimes. It can help with therapeutic drug monitoring. And so, first of all, we did the initial kind of scan versus our dish diffusion, and that produces a categorical agreement. Does the S, does the I, and the R, does it match up with what the new technology is giving us? And we had a 96% agreement, which is very impressive. And so we are moving to, and have been working on, comparing the MICs with the gold standard, which is Broth Microdilution, to be able to get a essential agreement. So looking at the comparison of concentrations, which is again really important when you're looking at the analytical performance of new devices. How does that impact clinical decision making? So a resistant antimicrobial or resistant bacteria from an AST result, it's quite easy to be able to talk to those clinical teams and say, you need to escalate your antibiotic therapy that they're currently on because your bacteria is resistant. That's a very easy conversation to have. Unfortunately, the opposite is not as easy. So if you, and it's not uncommon, luckily, we still have fully sensitive organisms that cause infections. So we have an E. coli, for example, that could be completely sensitive to all the antibiotics that we would use. So sometimes we have those scenarios where the patient is on broad-spectrum antibiotics, something like tazocin, and actually they could be de-escalated to something like amoxicillin. But the impact of rapid diagnostics means that you get a result back when the patient's still really sick, especially if they're maybe on ITU or HDU. So having those conversations is actually quite challenging because often the clinicians actually we just want to wait and watch, and maybe they're too sick for us to de-escalate the antibiotics. Because not always, might not always be what is causing the whole picture. Remember, a blood culture is a one picture in time. At that time point, you've taken a blood culture, that you've grown a bacteria, doesn't necessarily mean that's everything that's going on. So sometimes we've had delayed, de-escalation. So the impact on stewardship hasn't been there. But that's where good relationships with the clinical teams are important in these kind of changes in practice. So what I want to be able to show is we've done, like I said, we've been looking at this type of technology over the last few years because we feel that this is going to really impact how we manage our patients. And prior to COVID, we were actually using one of the first rapid susceptibility systems, which unfortunately was stopped during COVID due to a lack of funds. But one of the things that we're looking to look at the impact of the clinical side of rapid results. So we'll be doing this with our BACTEROMIC study, and this is what we do with all diagnostics. We look to see what the clinical impact is of the diagnostics. So this is some data from a few years ago where we were kind of retrospectively looking, initially retrospectively, then prospectively when the test was used in clinical care, was to look at what type of impact there was. And we were collecting this. So we're looking at as you can imagine, the optimization of treatment, which is a fairly straightforward metric. You know, have we changed because we found that it's a resistant organism, different, and it would not be covered by what they're currently on. Then it was narrowing of antibiotic spectrum. This is our kind of stewardship kind of tool. Are they on a broad spectrum antibiotic, and we can reduce it to a more narrow spectrum? A reduction of overall antibiotic consumption is often a metric which hospitals are collecting. Obviously, empirical therapy is often more than one antibiotic, obviously to cover as many bases as possible. So can we reduce the overall amount of antibiotics? Then there's kind of IV to oral switch. IVs obviously are important and get antibiotics into the system quickly, but they are also a portal of entry for infection and nosocomial infections. And of course, you're all well aware of this, being an infection control conference. And then in infection control interventions, this was a nice one, because obviously there are limited side rooms in most hospitals in the UK. You know, we often refer to them as like, you know, side room top trumps, which infection is going to be the most warranted to use the limited amount of side rooms. So if we detect a multi-drug-resistant organism faster than normal, then actually you're taking that patient off the ward much faster than you would have done, and they're in the side room, so you're less chance of that patient spreading the infection. So the impact we also looked at, particularly at the time we did this, there was a national sequence, so a quality improvement drive to reduce the usage of tazocin, so piperacillin, tazobactam. So we specifically picked the antibiotic to see how that would impact. And so we looked at the analyzed projections for 100 signal-positive blood cultures, and we noted that with the impact of those, 5,500 doses were saved per year for PIP-Taz. So 2,500 doses saved per annum of total antibiotic usage. 1,278 patient exposure days to multi-drug-resistant organisms. So these is a metric where we detected patients with a multi-drug-resistant infection, and we were able to get them in a side room faster than if we'd used standard of care and be able to then. So this is less chance to impact the environment, less chance for them to other patients, or even spread to staff who can then spread to other patients, because we all know that good hand hygiene is always a constant battle in hospitals. And the clinical actions were a mean 1.5 days earlier compared to standard of care, so they're quite significant. What we also did was we did a retrospective cohort study where we selected 80 patients and we matched them with 80 patients who hadn't gone through standard of care. So we used a Charlson Comorbidity Index to, as best we could, collect a cohort of patients that we could compare favourably, as best we could, reducing the incidence of bias as much as we could. And we selected 80 patients, and then we did some statistics just to show that there was, these were some metrics which were fair to use. And then we kind of compared them. Bearing in mind this is only 80 patients, it wasn't quite statistically significant, but at the time, COVID was just kicking off, so we're trying to finish this piece of work before we're all absorbed into that. So we showed there was a significant mean decrease of PIP-Taz, so that was a nice statistical incidence, and there were some good trends around reducing carbapenem doses. But again, there wasn't a big enough statistical pool of data to be able to show any significance or reduction in readmission or mortality. Unfortunately not. So these are the clinical interventions I mentioned on those 80 patients. So there was 170 different clinical interventions based on those 80 patients. So we had 70 optimizations of treatment, 30 narrowing of spectrum, 27 reduction in overall antibiotic use, 24 IV to oral switches. We had 19 infection control early interventions. So I've kind of whistle-stopped through that. Now back to that clinical case where the oncology ward had had a previous outbreak with this multidrug-resistant Pseudomonas, and a patient had a positive blood culture with an identification of a Pseudomonas. And this was late in the evening. I don't know if you're probably aware, and you probably have this all the time, these types of results always seem to happen at the end of the day or on a Friday evening. And this, again, was late in the evening. So there had been a previous problem. This had been found in the drains, as with most, if you go looking in the drains of most hospitals, you'll find multidrug-resistant organisms. But the fact that we discovered this actually led to a change in the types of sinks that we use in the haematology oncology ward. So the results came off at 12:30 at night. So we'd set up an alert system to the on-call microbiologists, so they were aware that this result was going to be coming in the middle of the night. So again, we're not wasting the investment in a rapid result. We're ensuring that actually we get value for money by acting on it, and that includes at night. So this was sensitive to colistin and amikacin, an intermediate to astrienam. It had the same antibiogram as the previous outbreak from 6 months previous, which was quite concerning because the sinks had all been changed. So there was a call from the team on the ward. Patient remained febrile. That's when the antimicrobial switches were made to colistin and amikacin. So there was a targeted change in antibiotic treatment and obviously an infection control intervention. So there was an outbreak investigation, and then there was actually a few more cases. But if this had been standard of care, this result would not have been known probably to the same time 24 hours later. So this potentially could have caused quite a problem in our haematology oncology ward. And it led to basically the whole place being ripped down and rebuilt because we just could not get rid of it. Okay, case study number 2. So 55-year-old female on ITU post-pseudomyxoma surgery. So our hospital is one of the European centres for pseudomyxoma peritonitis surgery. This is an extensive abdominal cancer, very slow growing, produces a lot of mucus, often requires 10 to 12-hour surgeries with a lot of debulking. So a lot of the abdomen is cleared of parts of the bowel, various organs, and so these patients are prone to soiling and infections, as you can imagine. So the empirical treatment is IV gentamicin and co-amoxiclav-ticaplanin, so very broad, about as broad as you can get. Blood culture, 8:30 in the morning, called to ITU, gram-negative bacilli again. It was an E. coli, but it was an ESBL. So this is an extended spectrum beta-lactamase producer, so it's going to be pretty resistant, not as resistant as a carbapenemase, like a CPE, but is still nonetheless a significant infection. So we phoned to ITU. This again was 5 o'clock on a Friday. If this had been standard of care, it would have been till probably Saturday morning, Saturday mid-morning. Patient would have been on suboptimal antibiotics. The gent probably would have done a little bit to it, but overall it would have been on suboptimal antibiotics. So we were able to rapidly change and manage that patient. So they went straight onto IV meropenem and gentamicin with immediate isolation of the patient. So this is a patient on ITU. So we do have some side rooms on ITU. Not every bed is in a side room. So we were able to optimize the treatment of a very sick patient. And obviously, we enacted an infection control intervention as well. So that is a brief tour of the impact of rapid antibiotic susceptibility testing using the BACTEROMIC system, an overview of previous work we've done showing how there is a significant clinical impact of having rapid susceptibility testing, how to implement. It's never easy, and at the moment there is no one shiny example of best practice. Everyone does things slightly different, which is the way of the NHS. But I think if we can improve the way we collect blood cultures, the way we improve transport to labs, start to harmonise how we identify and act on rapid results, we can see a real improvement in this sepsis pathway. And I think that's the reason why people like me are always looking to implement innovation, looking to see how we can improve what we do and work with our partners in industry to maybe improve what we do. And these really exciting projects. So we'll be working on more of this project with BACTEROMIC and to see how rapid diagnostics can improve patient care. So I'd like to thank some of my team. Again, this is a BMS project of one of my MSc students, Tom Hatcher, but Alice Goring has worked on some of our other rapid AST projects, and everyone at Hampshire hospitals for facilitating this.